Hello, everybody. Welcome to our webinar today. We are going to give it a couple of minutes so we have more people join. I'm seeing the counter go up, and I know we had over 1,700 people register today. So we're going to give it a minute so that people can join, and then we'll get started at about 2 minutes after the hour. We will be starting here in about 30 seconds. The counter keeps going up, so we're at 575 right now, and we're giving a couple of seconds here to get most people into the webinar. We'll be starting here in about 10 seconds. All right. I'm seeing the counter keeping going up. So as people come in, we'll just get started and people come in when they come in. But welcome everybody to this webinar titled Best Practices for Data, Sharing Innovations and Best Practices for Grantees from Grantees. My name is Shoma Ghosh, and I am an Associate Vice President within the Behavioral Health Group at Westat. For those of you who don't know, Westat is a employee-owned corporation located in Rockville, Maryland. We do a lot of federal contracting work across the Department of Health and Human Services, including with the Substance Abuse and Mental Health Services Administration, or SAMHSA. I'm coming to you today from Appleton, Wisconsin, where the weather is always not optimal. So we're on the cusp of spring and summer here. So it's about 59 degrees, windy and rainy. If you don't know where Appleton is, it's about 20 minutes from Green Bay, 2 hours from Milwaukee or Madison, and like 3.5 hours from Chicago. I'm part of the leadership team of the SAMHSA Center for Financing Reform and Innovations. We call ourselves CFRI for short because everything has to have an acronym. This CFRI is a really fun and rewarding contract for me personally, actually. We produce lots of reports, journal articles, issue briefs, and they're all related to finance issues that are happening related to mental health and substance use, prevention, promotion, and treatment. We've done really fun things like we have a series of journal articles that focus on school-based mental health promotion and prevention programs. 3 of our articles have just been published this month in Psychiatric Services. We have a fabulous website, which is listed on your slide right now. It's www.samhsa.gov/CFRI. And you'll see there are many of our reports, like we did one on coordinated specialty care for first episode psychosis and financing strategies. And it's a growing website, but what we're here for today is a series of issue briefs, 6 issue briefs, hot off the presses, that you will be able to see on that SAMHSA CFRI site now, and you'll be able to download them whenever you want to. They just got released today. These issue briefs focus on best practices that we identified from talking with SAMHSA grantees, like many of you here on this webinar call. And we also talked to SAMHSA project officers who oversee the grant programs. And what I love about this webinar today, and I've been sitting in on dry runs and stuff for it, is that we have brought together a group of grantees, SAMHSA grantees, who are going to be part of a panel and talk about their experiences and some of the things they've done to make data collection work within their grant programs. So I think you guys are going to love it. So before we get to any of that, I do want you to, I want to cover a few housekeeping items. So first of all, as I mentioned, we have nearly 1,800. The exact number is 1,794 people registered for today's webinar. That is, it just tells you the importance and the interest in this topic about grantee data collection and how to make that work. The webinar is being recorded, and the recording, along with the slides from this webinar, will be posted on the SAMHSA CFRI website that I keep talking about. And everybody who registered will receive an email when when all of the, when the recording and those slides are ready for you. They'll be 508 compliant and ready on that website. With the exception of our speakers today, everybody coming into the webinar is coming in on mute and with your videos turned off. That's just because we want to maintain a high quality recording of today's webinar that we can post. I'd like to draw your attention to two items on your webinar console. One is a Q&A widget, and the second one is the chat widget. The Q&A widget is where you can type questions that have to do with anything from I'm having problems listening to what did she say about the website where the slides are going to get posted. But you can also use the Q&A widget to ask questions of any of the speakers. We will have a question and answer session at the end. And we actually asked you all to submit questions when you registered, and we did look at your questions when you registered, and those have been incorporated into today's presentation. But if you don't hear the answer to your question that you put, either you want to put in the Q&A or that you put in before, ask it again, and if we don't get to it, we will email you the answer later. You can type it in at any time. You don't have to wait. And you can check in that Q&A widget too, because our speakers will also be responding in real time to a lot of those questions. The chat, I don't feel like I need to say a lot about the chat because I feel like you all know what you're doing with the chat. Feel free to network, feel free to tell people what the weather is like where you are and whether or not you're in Wisconsin or whatever. So with that, I would like to tell you a little bit about the agenda for this webinar. So during the webinar today, we'll hear opening remarks from Naomi Tamayasu, and then we will go into an overview of that newly released 6 issue briefs. David Berry will do that. And then after that, we will go into a panel discussion moderated by Howard Goldman. So before we get to and then we do the Q&A and everything. So before we get to that, I would very much like to introduce Dr. Naomi Tamayasu, the director for the Center for Behavioral Health Statistics and Quality, or CBISC is what they call it. Previous to her work at SAMHSA, Naomi held leadership positions in various federal agencies, including the Veterans Administration, Center for Mental Health, Centers for Medicaid, and Medicare and Medicaid Services, and the Health Resources and Services Administration. I'll turn it over to you, Naomi.
Well, thank you so much, Shoma, for that welcome. I have been around the block at HHS, and all that tells you is that I'm kind of old. But I've been around the block. I wanted to welcome you all to this very exciting Best Practice for Data webinar. I understand that we are close to 1,800, yay. And, I am now firmly convinced that anytime a presentation or a webinar on data appears, people come out in droves, whether they're frustrated, excited, they want to learn more, it brings out a lot of people. So I am so thrilled that we have this many people who are interested in data. I am also grateful that, we, Office of Evaluation within CBIS, was awarded a CFRI grant to develop practical data collection best practices for SAMHSA's discretionary grant programs. It's an internal, award, but it was a tough very tough competitive award. And we are so grateful for Trina Dutta, who oversees the C5 program, and all of SAMHSA for giving us this opportunity to develop the best practice for data series. Just a little bit of a background. Many of you know this. In FY 2022, SAMHSA funded $5.9 billion towards discretionary grants, which represents quite a substantial investment in the behavioral health safety net in the United States and territories. And as many of you know, and probably this is the reason why you're here, all SAMHSA grantees are required to collect data as a condition of their funding. We believe, and I think everybody believes, that without high quality, complete data, including timely follow-up data, it's virtually impossible to discern grantee performance, including the effects of these programs on behavioral health disparities. So understanding the data and best practices related to data collection really helps SAMHSA determine the true reach of programs aimed at delivery system reform and the extent to which they are or are not addressing the needs of the most vulnerable and under-resourced individuals. Data collection is also essential to make evidence-based decisions. The data you collect helps tell you what's most effective for your clients, and it informs SAMHSA, us, about decisions related to policies and programs. So sharing these best practices for data aligns with SAMHSA's true mission for behavioral health treatment, that is, supporting better outcomes for the people we serve. We hope that the best practice for data today, as well as the briefs, as well as any subsequent activities related to these series, brings together innovative and best practices that you, grantees, can and will use to address the most common, complex, and costly challenges associated with grantee-required data collection activities. And this is going to be discussed later on, but some of the products that we have put out, and some are really hot off the press, like they went out this morning, as well as the webinar. I hope that these issues provide an opportunity for grantees to learn from each other about what works, so that we can reduce the trial and error and the frustration that grantees have in order to, when they try to figure it out all by their lonesome. Essentially, the best practices in these series are for grantees, from grantees. They're coming from you. And this is an opportunity to kind of help each other, share best practices, and hopefully we can all achieve the same goal of serving our patients and our clients to the best possible ways. The best practice for data includes 6 issue briefs. The panel will be discussing some of them. But just to give you an idea on some of the topics, one incorporates technology for data collection and reporting. Another uses data to monitor progress and tell your agency's story. Another brief is focused on establishing data protocols for optimizing data collection. Another is hiring effectively for data roles. I know that's been an issue for many of you. Another is managing data collection for multiple SAMHSA grants. Some of you have been very fortunate to get numerous grants from various centers and offices. And lastly, but not least, we want to help you understand the unique data concerns when working with tribes. So we hope that these issue briefs and our panel discussion today will give you some ideas for tackling those challenges associated with collecting data. And as many of you know and probably heard, we are constantly hearing you all. We are trying to improve as we speak and streamline the GIPRA data system. So the advice that you give us, the comments that you provide us is not being wasted. It is being used to improve our data collection system. And I hope that the panel, as well as some of the information and the inputs you provide today, you can give them honestly. We will take them and we will use them to do quality checks as well as improve our data reporting system. Lastly, I want to thank today's speaker. I know that they're going to be thanked many, many times, but I want to thank our speakers and expert panelists because that's the core of today's webinar. I want to thank David Berry, Howard Goldman, Christopher Kluke, Eric Sagal, Brooke Toll, and Kimberly Truong. I also want to thank my colleagues here at CBIS, Tanya Geiger, Marie Tate, and Regine Bumper. They have been tirelessly working from this end to get this project going. So I want to personally thank them for their hard work. And I want to give special thanks to Westec for the work that they do on CFRI and putting this wonderful webinar together. So I'm so thrilled to see many of you join today. Thank you to all of you for making time to learn about this important subject. And I'm now going to relay it over to Shoma to then start the webinar panel. Thank you.
Yes, thank you. Thank you for the kind words. So I'm looking at this counter and we're up to 825 people, which I'm super excited about. So next, we will have David Barry come on and talk a little bit about these 6 products that we told you is just the 6 issue briefs that are on the SAMHSA website today that are free of download to you. David and I have been friends for a long time, and the last time we worked together was on the Certified Community Behavioral Health Center revision of criteria, where both of us were working so much and had so much on our plate that we could only meet like before 8 or after 5. And so he'd be talking to me from the bus stop with his daughter. So yeah, we didn't have quite that experience working on this project, but I always love working with David and listening to him. He has this humor and optimism that I just love. So with that, I will turn it over to David Barry.
Thank you, Shoma. So I'd like to talk about the best practices for data series. So while serving in my several roles in SAMHSA, I've learned that grantees often have a lot of questions related to data collection. Grant data collection can often be complex and is generally very different from the service work that grantees engage in day to day. So SAMHSA has heard these concerns, and we wanted to find a way for grantees to share their best data strategies, to learn from one another, and to have recommendations on how to get started with better data processes. So beginning in June 2023, SAMHSA began listening sessions with a variety of grant stakeholders to identify some of the most innovative and best practices for grant data collection, management, and analysis. So you could see the timeline of the project depicted here in the slide. As Shoma mentioned during the opening, we spoke to GPOs, state leadership, and most importantly, grantees that are using these strategies. We spoke with individuals involved with a variety of grant programs, including the Tribal Opioid Response, Certified Community Behavioral Health Clinics, CCBHCs, State Opioid Response, Project Aware, Tech SP, Strategic Prevention Framework, Partnerships for Success for States, Targeted Capacity Expansion for HIV, and the Minority AIDS Initiative. The final products of this work are 6 issue briefs, which I'll discuss next, and this webinar, which includes a panel of some grantees who helped inform these issue briefs. They're here to share some of their experiences with grant data collection and to discuss some of the best practices that they feel have been most beneficial to their programs. Next slide, please. So these are the titles of the 6 issue briefs that came out of these listening sessions. There's a link here to download the issues briefs, but we'll also share this link later so that you can access the briefs that seem most useful to you and you can read them more in depth. So after the listening sessions with the GPOs and grantees, in particular, these were the 6 topical areas that grantees both asked the most questions about and had some of the most innovative strategies to address. So I'll go through a few highlights from each of these issue briefs now, but I really implore you and encourage you to download them from the CFRI website. Next slide, please. So some of the concerns we heard were that data collection is time-consuming, has a steep learning curve, and is resource-intensive. This can be especially true for grantees that are working in rural or underserved and under-resourced communities. where small staffs often have to wear a number of different hats. Grantees shared different technology that they use to make their data collection faster, more accurate, and more efficient. Some of the resources discussed include software they already had access to in the course of their day-to-day work, and SAMHSA resources for batch reporting of client data. Although there are more sophisticated options that may require additional costs, many grantees noted that learning to use the software they already had in their possession and access to really helped a great deal. Next slide, please. Grantees also noted that data collection could feel overwhelming. This was particularly true for grantees that had clinical staff doing data collection. First, clinicians already have a lot on their plate. In many areas, the need for the services grantees provide exceeds their ability to supply those services. Additionally, with too many people involved in data collection, there can often be too many cooks in the kitchen. It's hard to keep track of timelines, identify who is supposed to report the data, and so forth. Some grantees have identified a data lead or an evaluation lead to take control of and track data tasks. This is an expertise that can be built in-house. Grantees noted that data leads often input data, report data to SAMHSA, track timelines for follow-up data collection, and that they become an expert in the data collection processes and data collection tools that are used. This also means that whenever someone has a question about data, there's a point person who will have the expertise on hand to help, or the expertise to know how to find the answer. Having a single data point person can centralize all the information related to data collection, management, and analysis, as well as data tasks and data task delegation. Next slide. This brief focuses on hiring for data roles. As discussed in the last slide, many grantees find having a data lead can create a lot of structure for data tasks and timelines, which can really increase accuracy, speed, and efficiency of data collection. However, sometimes there isn't someone in-house who has the capacity to take this work on. In this case, some grantees have hired specifically for data roles within their organization. Hiring for data work is much different than hiring for service provision work, and is often something that grantees do not feel equipped to do. The best place to start is thinking about what exactly you need your data lead to do. Are you looking for someone who will collect, enter, report the data to SAMHSA with no further involvement? Or are you looking for someone who can analyze your data for you to identify your trends? The job ad and the employee you ultimately hire will look very different from each of these roles. Knowing ahead of time what types of tasks you like your data person to engage in, it's vital to identifying the best person for the role and ultimately to retaining that person over time. Next slide, please. This issue brief focuses on managing data collection across multiple grants. Data collection can get much more complicated if you have multiple grants through SAMHSA or through other federal agencies. Grantees with multiple grants often noted that different timelines, different requirements, different question tools, so on and so forth, could really feel overwhelming. Some grantees noted that sitting down at the very beginning of the grants and comparing the requirements was helpful. Identify what questions overlap between them and which ones are different, and identify timelines for data reporting to SAMHSA and for follow-up interviews. It may be useful to identify a lead for each of these grants that you have. This person can be an expert on the requirements for that grant program and can keep track of timelines, tasks, to make sure all requirements are being met for each specific grant. Next slide, please. This issue brief focuses on unique challenges when working with tribes and organizations that serve tribal communities. Tribes are sovereign nations with their own laws and policies, but also within their own unique culture and customs. When collecting data from tribal members, it is important to remember that all data belong to the tribe and should only be used in ways that have been explicitly agreed upon with tribal leaders and representatives. It's best to have a formal agreement, such as a data governance framework, that directly outlines the rules related to data. Who has access? What can and can't be done with the data? Who within the tribe has the authority to make decisions about how data are used? This should be a living document that is revisited at regular intervals to make sure that it is still comprehensively covering all aspects of the data and any issues or concerns that arise. If there's ever a change or an issue that is not clearly represented in the data governance document, these should be brought up to the tribal leadership promptly and should be rectified in the data agreement. Additionally, it is important for GPOs to collaborate closely with tribal leaders or stakeholders to find ways to make different collection meaningful for them. What do they most want to know? What are the priorities they have identified? How can you help them understand these priorities better? And finally, as grantees gathering the data, you often become data experts. So how can you help build capacity for data collection, management, and analysis within the tribes that you work with? These are all different things to keep in mind and consider. Next slide, please. Finally, this issue brief is pretty important to work so many of us do in communities. One of the most frequent best practice we heard from GPOs and grantees alike was that making the data useful was one of the single best practices they engaged in. By making the data collected important to your organization, your community, your policymakers, etc., you create buy-in from your staff, your clients, and the individuals in your community. Grantees discussed having regular meetings with staff to discuss data and outcomes. This can show progress over time and answer, are you offering more of a particular service? Are client outcomes better for those who engage in a particular service? It can be easy to lose sight of a bigger picture when doing the work every day. Showing progress over time can help remind your staff why this work is so important. Or this can show gaps. Are there populations that appear to be particularly underserved in your community? And are there services that are needed that are not currently being supplied? This can help you identify areas where your organization needs to grow in order to serve the needs of your community. So these are the 6 series pieces that I want you to keep in mind, and as we said before, please consider downloading and reading these in detail later on. I'd like to now pass the microphone off to Howard Goldman, our moderator for the panel. Howard is a professor of psychiatry at the University of Maryland and has worked closely with CFRI on this and all other projects. Over to you, Howard.
Thanks, David. I think we have an interesting panel discussion. I know we have outstanding panel members here. We'll spend probably the next 20-25 minutes focusing first on the data collection issues, some of which were part of the issue briefs. And then perhaps we'll have some time to talk about how these data might be used. Our 4 panelists today are Chris Cloquet, who is the Director for Data Science at the Manchester, New Hampshire Certified Community Behavioral Health Center. We have Brooke Toll, who's a Master's Social Worker and also the Data Manager for the Tribal Opioid Response for the Chickasaw Nation in Oklahoma. We have Eric Sagal, who's a Project Evaluator for the North Range Behavioral Health in Greeley, Colorado. And fourth, we have Kimberly Trong, who's the Lead Evaluator for the Greater Nashua, New Hampshire Behavioral Health. So the first question is going to Chris, and it was an issue that was raised by David in his presentation. How have you navigated collecting data from multiple SAMHSA grants at the same time within the organization?
Thanks, Howard. Yeah, at the Mental Health Center for Greater Manchester, we have a long history of receiving grants through SAMHSA. We've received over a half dozen over the years and currently have 4 active. They they cover a wide variety of programs, including center-wide initiatives such as Zero Suicide, CCBHC, as well as more specific initiatives such as working in local schools and training for community members and community providers. With that in mind, managing that is a challenge. And so one of the ways that we handle that is, while we do have different leads for each of those projects, we also have common members who tie that all together. I'm one of those members. I am the grant evaluator on 2 of those grants, and for the other 2, which are larger initiatives and really require an individual solely dedicated to them, I work closely with that individual to try and coordinate data collection efforts. And so I really feel like a lot of this starts right at the application phase. For us, when we are applying for a new grant now, we usually meet and we make sure that there is someone in the room who has implemented one of our other grants. We also make sure that someone who can speak to data collection options is in the room, because some requirements from SAMHSA are pieces that they require, but you also get to list certain goals and outcomes that you want to measure. And when you're doing that, it often helps to try and keep in mind, what are we already collecting? What can we use for more than one purpose? And so because of that, it reduces burden on clinicians as well as other areas. We also then have a central repository for each of the grants. Each grant, we usually make a dashboard using Power BI. As a central, there all grant documents go. We are able to keep a timeline of what's due and to be submitted, as well as live tracking of outcomes to link it within our electronic medical record. I know someone was asking what kind of data you can use, what kind of systems you can use to collect measures such as GIPRA and NOMS. We use our EMR. I've also heard of options such as Red Hat as well, and pieces related to that. Collecting it before you put it in SPARS can often be very helpful when you have multiple grants, because then we can track, is there someone who is eligible for multiple grants and we only need to interview them once? That's a really useful tactic. The other piece is when interviewing and talking back and forth between the different evaluators who are collecting information for NOMS and GIPRA, it's important to learn from one another. From a grant we have that works in local schools, we were able to discover that trying to get reassessments for NOMS was much more effective for children in the evening. And so because of that, we then took that information and spread that to all of our other grants as well. And so I know there was a question before the that was submitted about how can we improve reassessment rate. That's one way. The other way we found is from another one, such as integrated care. We found that having someone call right after an appointment and having the clinician remind the person they're going to call made it much more likely they would pick up and do an answer.
Right.
So these are some.
Let me just stop you a second. I'm sure that others of you are also responsible for multiple grants. I wondered if you had anything you wanted to add to what Chris has said so far. I know you talked about interviewing, and I know, Brooke, you're going to talk about that probably later. But I don't know whether the 3 of you have anything you'd like to add. Eric,
I'm only responsible for 1 grant, so there's not much that I can add to this.
Right, you do the TOR project for the Chickasaw Nation. All right, well, I interrupted you, Chris. Did you want to finish up?
Oh, just the only other thing I would say is for us, integrating into routine workflows is something we're trying now that's also been essential. And it's something we've actually learned from Nashua a bit, which is Kimberly, the institution Kimberly's at, where integrating it into, we're starting to ask some of the questions from NOMS to all of our grantees, not just, to all of our patients, because we find the outcomes useful.
Great. Eric, I wanted to shift to you to think about technological solutions to some of the ways you incorporate that into your data collection and reporting processes.
Hi, I'm Eric Seigel. I'm with North Range Behavioral Health in Greeley, Colorado. We are the Community Mental Health Center in Weld County, Colorado. We started as a COVID expansion grant for CCBHE, then became a CCBHE IA grant. And one of our goals was to create an access team that was interviewing and providing initial services to clients needing assessments, and those would be the people identified for NOMS collections and then sampled for SPARS entry. Also moving towards having the entire agency completing NOMS. We're probably at 30 to 40% of the agency because we're not collecting NOMS on some of our specialty programs. When I took over as the evaluator, we were collecting NOMS on PDFs and then converting them to Excel and then hand entering. And one of the immediate issues that we noticed was that there would become times where the person who was doing the data entry had to become the translator for the PDF, had to make decisions about how it was answered, and at some points you couldn't really feel comfortable with the data validity because of those decisions being made at the moment. So we wanted to, one, automate our process as much as possible, but also build in steps into that automation that made sure that the data that we were collecting on every single client was based on the same criteria and not being looked at through different lenses. We also wanted to make sure that our clinical staff, that entering a PDF and then turning around and getting it entered into SPARS was very labor intensive for our clinical staff. So the other concept we have in that automation was to get the clinical staff to being able to do clinical work, including that our access team is the primary, does the primary assessment, the NOMS interview, and does the initial state reporting for the client. And we wanted that to be their main input. So our first effort was to get it into our EHR, and our EHR had a product and we used that product, but we adjusted it for our own needs. And that later became not a huge issue, but when we would have wanted to have designed the document or tool in our EHR from scratch. But once that was created in our EHR, we were then able to take our NOMS and using Microsoft SQL Server, move that data into a data warehouse. And then initially we created a robotic process automation using UiPath, and we literally had a robot sign into SPARS and using the spreadsheet generated by a Tableau prep, entered all the items. But when they were going to go into the batch system, we wanted to be able to change that. So we took our core reports and our core, converted it to being able to use the batch process. Our concept of automation was always, what are the steps that we can automate it, even if it's a report that puts everything in the right format, or in our one case for a while, a robot that enters the information. And one of the big lessons that we learned is that if you have those automatic systems, you can put checks and balances into them so that you increase your data validation and data validity. We also have a very good outcome on getting things into SPARS. And because we freed up clinical time, we have a very good reassessment rate. Discharge rates, maybe not as much.
Yeah. Eric, I wanted to know if there's anything that didn't work so well for you. You've got those robots working for you. I'm sure some of the people are happy to be replaced by a robot when it comes to data collection rather than doing their clinical work. Does anything not work well for you?
One of the main problems was relying on that third-party vendor to create the original NOMS, because they created it very well. I'm not at all speaking down to our EHR, but it was not set to the coding standard as listed in the code books from SPARS, so that when we went to the batch system, we had to translate the entire system. I mean, literally down to, in our system, yes was coded 5, no was coded 10, but in SPARS, yes was coded 1 and no was coded 0. And so we had to take that entire data set and reconfigure it. So one of our lessons learned is if you can create your own collection tool, grab those code books and just make it match exactly, because when we've talked to people who've had a problem with the SPARS batch upload, it's usually around those issues. Once we understood the code book, we have really had no problems with the batch upload.
Well, Eric, you've been talking about robots doing this work. We want to shift to the human side of some of the data collection, and that's where Brooke comes in. We're interested in some of your tricks with respect to getting interviews done and doing them correctly.
Sure. So the main difficulties that we have with getting these GIPRAs, these interviews done, kind of fall into 4 categories. Locating clients and getting them on the phone in the first place can be difficult. Client buy-in, having them agree to actually go over the survey. Issues related to the GIPRA itself, the phrasing of the questions, and making sure that the way that you interview is allowing you to obtain accurate information, and logistical issues related to recording the data and entering it into SPARS. And so I'll try to touch on each of these briefly. So as far as locating clients, Christopher already mentioned that it can be helpful to have them reminded if they're, going to have access or have a point of contact with your organization. You can remind them at that point of contact, at that meeting, hey, someone's going to be calling you, and it's likely that they'll pick up. For us, that can be difficult because we do have medication assisted treatment clients who will be coming in every month, but we also have sober living and treatment clients who, they might just kind of fall off the map after a few months. And so I'm just kind of cold calling them, hoping that they'll respond. I try to call clients about once a week. We have a 3 or 4 month, depending on whether they're homeless, time to try to reach out to these clients. And so I try to keep my call frequency to a point where I'm not like harassing them, but also it gives me, 9, 10, 12 attempts before I give up on a client. And sometimes, I've called someone 8 times and on the 9th time they pick up and I get the GIPRA. So that can be helpful. Client buy-in can be difficult just because I'm cold calling. There's so many spam calls these days. It's hard to get people to believe that, yes, I'm actually calling from the Chickasaw Nation Medical Center. I actually just have some questions for you. I'm not like trying to steal your data or whatever, especially because you're supposed to confirm that they are who they are by checking their date of birth before you start doing the questions and before you can tell them, hey, I'm calling about the MAC clinic or something like that. And so sometimes I have to, really be understanding and be like, look, I understand why you would think that this might not be legitimate. I really am just trying to get this data. And usually between that and having a $30 incentive that we're able to offer, usually I'm able to get people to buy in.
That
And
helps.
so, yeah, it's very helpful. We can't do that for the discharge, unfortunately. And so once we actually start the GIPRA, I mean, I could go on about the GIPRA for a long time, but I'll just give a few examples of what can be difficult about it. So first of all, the beginning of section B, which is where you start for the follow-up GIPRA, immediately starts with asking about substance use. And that can be jarring for clients who, answered a cold call and weren't expecting to think about this today, And so before I even start asking questions, I always tell them your answers will be confidential. Your name will not be attached to this assessment and reporting. You're also welcome to decline to answer any question for any reason. So I have to ask all the questions. You're welcome to say, I don't know the answer to that, or I don't want to answer that. And that's perfectly fine. Just let me know and we'll move on to the next question. Because if you don't make it clear to them that they have autonomy in this situation, it can be scary. You know, you open up with asking about substance abuse, and I've had some clients be like, whoa, 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 you know, even when I've, you know, laid that all out and be like, actually, I don't know if I can do this right now. And often if that happens, I'll have to kind of pivot and say, okay, you know, we don't have to talk about that right now. I'll move over to some more like quality of life questions, you know, and kind of skip around the GIPRA. And usually by the time that I get back to that question, we've built enough rapport from talking through what's going on with them that they are willing to answer those more difficult questions.
You have a lot of trouble with people breaking off before the end of the interview, or are you able to, once you engage them, to keep them going?
I don't have a lot of trouble with that personally. It has happened a couple of times, but generally once they buy in, they're willing to do it. I think that the gift card incentive helps. But also I think it's very important to always remember the dignity and the worth of the person that you're talking to. It's part of the social work code of ethics. And so every question that I ask, I'm trying to convey with my tone, with everything, that I am not asking these questions to judge them. Like sometimes I'll literally say, if they're hesitant to talk about substance use, like, I don't care what you're doing. You know, this is just data for the people who pay for this treatment. And so generally they're willing to answer.
Yeah, I
But
think respect for, you know, the participants in our programs and the respondents to our questions is a good first principle. I want to
absolutely.
make sure that we have time to get to Kim. And we wanted to find out from you how you're able to get some of these aspects of data collection worked into the workflow in your organization.
Yeah, hello everyone. Thanks again for having me today. So I was very fortunate to have had plenty of preparation time upon my agency being awarded the grant. It was about 3 to 4 months before project launch. I also originally started at my agency doing case management for 2 different departments, which helped me see the inner workings at the ground level, as in, how can we pitch this need to our clinicians? You know, a need that may seem periphery in comparison to the crises that a lot of clients find themselves in on a regular basis. So in thinking about answers to these, after training, preparations were made to ensure 2 things. One, we conduct agency-wide presentations, and that needs to occur prior to and throughout data collection. And 2, the baseline evaluation is embedded into the intake workflow now. So first, the presentations, they allow for staff to feel more knowledgeable about CCBHC, particularly the evaluations component. We know that when people have more information on a topic, it can foster more confidence or willingness to engage in conversations about that topic. So all teams and departments were reached. This actually includes our board of directors and senior leadership team, and occurs about 2 to 3 times per year. We also reach admin staff in addition to the clinicians, just because we believe that it's important that every staff at every level has been offered information about the grant and why it's important to learn about. And on the latter point about our intake workflows, I'm not going to lie and say it was seamless getting the NOMS baseline into intake, but we use like an opt-out versus opt-in method, and our information sheet kind of explains the purpose of data collection and everything. And we also inform the client about random selection that occurs in 6 months to get a reassessment. And upon explaining the purposes of all of that, and the impact it has on increasing access to treatment, people are typically agreeable to helping the greater cause. We also take vitals at intake. That's a whole new thing. The evaluators are doing that. got training on it, and you know, that helps our agency meet program specific health metrics like blood pressure, height, weight. We do plan on adding a health screener later this year to identify smoking status and any other health related risk factors. But our team believes that these strategies helped us best successfully capture the baseline evaluations, and it does help with our reassessment rate as well.
Yeah, so when you said vitals, I thought you were using it euphemistically, but you mean it in the medical sense, medical context. Listen, do any of you have any wisdom you'd like to impart from your own experience about using these data? I mean, I realize that it's a accountability issue with the federal government to collect the NOMS and GIPRA, but we like to think that we're working in learning healthcare systems. And I just wondered whether you had anything that you wanted to add about how you might have used the data in the last minute or two that we have.
On
I
a
can
more individual, sorry, Christopher,
No,
I'll
go
go
ahead.
quickly. On
No,
a
I
more
think people
individual
did correct.
basis, you know, we have questions asking about suicidality. We have questions asking about depression and anxiety and that sort of thing. And so in that moment, you want to be able to respond. And at the Chickasaw Nation, for instance, I mean, we have outpatient, we have intensive outpatient services, we have residential. So at that time, I can, you know, validate their feelings, talk briefly with them about what they're going through, and also give them a referral or, you know, give them a phone number to call and encourage them to call that number. And so that's a way that in that moment, you know, not even while we're aggregating data, we're using that data to follow up with their well-being.
So that's the clinician in you speaking about using it at an individual level.
Exactly.
I wonder, Christopher, were you going to talk about a way that it's used at the organizational level or the team level?
Yeah, we use the data in a couple of different ways. The most obvious, we actually collect some of the NOMS information without it being connected to any grant, because we've shared it with city officials regarding some of our court diversion programs, as well as improvements related to that. And also we've used it for quality improvement regarding disparity impact to find groups that were underserved as a result of our first CCBHC grant. But probably the biggest one goes back to what Kim was talking about earlier, and that's staff buy-in. People are clinicians, and we work for nonprofits because we want to help people. And so whenever we're asking someone to take time away from that for data, that's an act of trust on the clinician's part. So it's really important, and we try and do that a lot at the center, that we return and show this is what we did with that data. This shows how many people you helped, and we know that because of the efforts with the data you did. These many people were able to get homes. These many people were able to get essential needs for the first time, or were discharged with treatment complete. That idea of trust is probably the central for what we do, and we've been paying it back.
That's great. That's a great way to end. We could go on for some time, I think, but there are questions from the other participants. And I just want to thank Christopher, Eric, Brooke, and Kim for serving on our panel. And I throw it over to, I think Victoria Nelson is handling the questions, or perhaps it's Shoma. But one of them will pick up from here. Thanks for your participation in the panel.
Yes, thank you, Howard, as well. And as you stated, my name is Victoria Nelson, and I will be fielding some of these questions. One of the questions that we got for registration, and we saw a couple similar ones, asked about the best practices for collecting both the questions that are required and for questions that might be more useful personally to the programs that you run or to your organizations. Have there been ways that you guys have incorporated sort of specific questions that relate more specifically to what you guys do into your data collection efforts?
I will say that we haven't done this yet, considering we're in year 2 of our PDI grant. But I will say that we got approval through discussing with our GPO that we can actually add items to our NOMS tool if we choose to use for internal purposes. And this kind of relates to what Chris was saying earlier about staff buy-in and the agency-wide educational piece, because I think that transparency is key. And so when you inform staff of, you know, the timelines and what you're using the data for, they actually receive the presentations well and are able to contribute. Hey, these are things that our team would be interested in learning about. If you can maybe consider including that in your findings for the next presentation, which occurs, you know, they occur a few months in between. So we are still working on that. Because our agency that we're actually implementing like a whole new med record system this summer. So like we've been a little slow going, but that is something that we are actively tracking now and preparing for in like the next year, probably.
Beyond the NOMs, we're looking at how to get all of the quality measures into all of our systems, you know, because there were portions of the social determinants of health that were not included in our assessment. And, you know, other portions of quality measures that were getting at the assessment and intake level. And our NOMS is flexible so that if we wanted to add, we could, but we've not gone that direction quite yet.
Fantastic, thank you. And then I guess I've got a whole bunch of questions here actually, but I'm going to go ahead and do one more quick one here. Are there ways that you guys have worked workflow into or work data collection into the workflow at your organizations? Or sort of made it like a regular practice with multiple folks?
We just recently started doing asking a lot of the NOMS questions that are required for the interview as part of our traditional intake. And the goal with that is then if someone is eligible for a grant for a baseline, they don't need to actually be re-interviewed. The intake has all of the information they need, and then that can be moved over into the NOMS form. And we can also use those at a 1 year. We're hoping to institute some of the questions at a 1 year follow-up so we can see improvement across our entire patient base, whether they're a member of the grant or not.
That's fantastic. So including those who even aren't necessarily getting the grant services. That's wonderful. Well, I'm going to go ahead and turn this back over to Shoma to close us out. But again, I wanted to thank all of our panelists and for the folks who have come and asked some really wonderful questions.
Yes, thank you, everybody. This was a fantastic webinar. And I mean, I really, the number of people who attended and stayed, I mean, this is a testament to how important this issue is. So again, I'd like to thank everybody for attending today and staying on. I know you're all busy people, so we really appreciate your attendance here. And look for other CFRI webinars in the future. We look forward to presenting to you again. Thank you.